Good morning everyone. Today I, Harsh Nawal, a final year MBBS student from Medical College, Kolkata, present the game of granulomas. A 47-year-old female presented to our clinic with shortness of breath on minimal exertion, with peripheral bipedal edema and heaviness in the right upper quadrant. She was actually a referred case who was referred to us after non-response to diuretics with a preliminary diagnosis of pericardial effusion of unknown etiology. On general examination, there was bipedal edema, hepatomegaly, and she was an NYHA class 3 patient. On cardiological examination, we found a normal pulse with an elevated JVP and muffled heart sounds. Laboratory investigations were mostly unremarkable, but we found mild lymphocytosis of 42% and an ESR which was elevated. So the chest X-ray and PA view revealed a water bottle appearance corresponding to pericardial effusion with an increased CT ratio. There was mild bilateral pleural effusion. So the ECG of the patient revealed low voltage QRS complexes, and there was electrical alternance which can clearly be seen in the chest leads. Echocardiography revealed a large pericardial effusion. The fluid width is mentioned. There was collapse of the right atrium and right ventricle. The IVC diameter was enlarged to 22 millimeters and it collapsed less than 50% on inspiration. We found LV diastolic dysfunction with a preserved LVEF. So this was showing a pericardial effusion with signs of tamponade. We proceeded with a CT scan of the thorax, and apart from pericardial effusion, it showed us a localized mass in the pericardial fat, which was possibly a malignance or lymph node, which was a very important finding in this case. We also found mediastinal lymphadenopathy. The first image, the arrow points towards the mass in the pericardial fat. And in the second image, which is the one below, we can see mediastinal lymphadenopathy. So based on all of these, we reached the diagnosis that this is a pericardial mass which has presented as a symptomatic large pericardial effusion with signs of tamponade associated with mediastinal lymphadenopathy. So now to ascertain the nature of the mass, we proceeded with further workup. We performed a pericardiocentesis on the patient to relieve him or relieve her of the symptoms. 720 ml of serosanguinous fluid was drawn gradually. The cytology revealed no atypical cells, protein was elevated, glucose was reduced. So this ruled out transudative causes for the effusion. We further went out to rule out autoimmune causes. We performed an ANA profile, anti-CCP and RA factor, which are all negative. This ruled out autoimmune causes. We sent a part of the fluid for CB-NAT, which turned out to be negative, which ruled out TB, which is essential in the Indian background. So the pericardial fluid analysis helped us to rule out transudative causes, autoimmune causes, as well as tuberculosis. And there was no history of trauma or any drug intake. We performed a CT-guided excision of a small piece of... the CT-guided excision was performed on the pericardial mass, which was found on CT, mediastinal lymph nodes, and the pericardium proper. So all three of these revealed non-caseating granulomas with giant cells, which led us to the possibility that this could be a case of sarcoidosis. So we performed the final further workup. The serum ACE levels were found to be elevated at 86 micrograms per liter. The serum calcium was elevated at 11.9 milligrams per DL, commonly seen in sarcoidosis. The bronchoalveolar lavage fluid showed a high CD4 plus CD8 plus T cell ratio of 3.3. The FDG PET CT scan showed increased uptake only in the mediastinal and pericardial lymph nodes. So in conclusion, this was a case of cardiac sarcoidosis presenting as a pericardial mass and a massive pericardial effusion. Points in favor of diagnosis: we found non-caseating granulomas in the pericardium proper, pericardial lymph nodes and mediastinal lymph nodes. We found mediastinal lymphadenopathy, and it was supported by the BAL fluid analysis. There was elevated serum ACE, calcium and vitamin D levels in the blood, and we have excluded the other etiologies in this case. So on definitive management, the patient was started on corticosteroids, tablet prednisolone 30 mg OD for 2 weeks, which was then tapered slowly, and the patient was kept under close monitoring. After a 1 week stay in the hospital, there was clinical and radiological cure, so the patient was discharged. So the take-home message is sarcoidosis is a rare but eminent etiology for cardiac disorders which can manifest in myriad forms, be it arrhythmias, pericarditis, myocarditis, heart failure. In our patient, it mimicked a pericardial malignancy. Definitive diagnosis for sarcoidosis is made difficult by the need for histopathology specimens. High grade of suspicion is needed to diagnose sarcoidosis early, and if diagnosed early, there is an excellent response and a good long-term prognosis which makes sarcoidosis a must-diagnose condition for the cardiologist and the physician. Thank you for your patient listening.